Good evening, everybody. It's a great pleasure to be with you today once again. I apologize to be only in video. I hope that we have the opportunity to meet together. This year, I was asked to talk about arteriovenous fistula for hemodialysis, and I focused my topic on the analysis of the tools to maintain this access patency and functional. I want to thank the organization committee for this kind of invitation. As we have previously shown that the arteriovenous fistula is preferred to central catheter, and when an access is proposed, the native fistula is preferred to the graft fistula, and the distal location at the wrist is preferred than the proximal location at the elbow. With this strategy, we have a better long-term secondary patency rate, we have a lower complication rate, especially ischemia and Steele syndrome, less hyperflow syndrome, less infection and thrombosis versus graft. With this strategy, we have also the preservation of the upper arm veins, and as we will see on the next slide, the durability of the fistula is depending on the location of the creation, with a better longevity for the cephalic at the wrist rather than the basilic at the elbow. The main weakness of this axis is the stenosis, which leads to thrombosis and the loss of the axis. Then angioplasty and especially fistuloplasty is now actually recommended as the treatment before the surgery of this axis. The indication of the treatment is leads on the association of the clinical signs of the stenosis and the hemodynamic parameters observed in dialysis or echo-Doppler examination. When we have previously performed a declotting of an axis, it is considered as a precious axis, and then there is a close follow-up by echo-Doppler or transonic or pressure measurement on hemodialysis, and we are encouraged to propose an indication of revascularization less quickly rather than the apparition of the clinical signs. When we deal of angioplasty of fistula, we have to consider the technical success. It is defined by residual stenosis less than 30%. You can find on some paper 30 or 50%, but the value of 30% is now well recognized. The clinical success is defined by the improvement of the clinical indicator, which leads to the angioplasty during 6 dialysis seances with 2 needles, and technical failure could be observed due to the dewaste of an adequately sized balloon, to the persistence of significant stenosis, to low flow observed on the angio, and to the persistence of pre-existing collaterals when you treat some central stenosis. If we have a closer look to technical failure, we can encounter two different situations. The first is the resistant stenosis. The second is the elastic recall or elastic stenosis. When you perform your angioplasty, in the first case for resistant stenosis, you can show the stenosis on your balloon, and you can't not inflate all your balloon. And when you perform your control, it remains significant stenosis. For elastic recall, you have a good expansion of your balloon, but after in the control it persists significant stenosis. In the first case, you can use high pressure or cutting balloons to obtain the dispersion of the stenosis, but in the elastic stenosis you can't upsize your balloon or use a stent. And this choice could be difficult, and it's the goal of my talk today. We have to deal with dedicated angioplasty balloon, high pressure, ultra high pressure cutting or cutting balloon. We will discuss about the stent graft, and it depends about the patient fitness, life expectancy, the topography of the stenosis, the number and the type of the previous intervention. For this topic, I have the first of the tool is the high pressure balloon. The second tool is the cutting balloons. The rationale of these tools is an alternative to high pressure balloon to obtain a more regular cut in the stenosis. The result is not so good as we expected regarding native or graft fistula. The increase of permeability could be observed at 6 months, but is not very durable, and it's not sufficient to consider for the first line treatment in the recommendation. Some studies are favorable for graft vein stenosis, but as we will see later, we have another option for this location with more good results. The third tool is the drug-eluting balloon. The rationale is not to obtain an immediate better result, but a better long-term patency. The plaquettic cell associated with the balloon limiting the neoantimal proliferation. Initial literature is not favorable for drug-eluting balloon, but if we have a closer look to the results, the concentration of plaquettic cell is not enough for the hemodialysis fistula, and more recent literature is more favorable for these techniques, but it's not durable. We have results, but at 6 months with significant differences between high pressure balloon versus a drug-eluting balloon, but at 12 or 18 or 2 years, the result is not significant. In meta-analysis with a larger number of patients, the differences is not clear, with at the author says a trend of higher target lesion patency, but we observe a significant lower rate of restenosis. But these two, I report the two last and the two main article on this topic, but with this result, we have no clear recommendation for the American Society. There is inadequate evidence for the use in first line or in routine use it's also the same cases for the European Association of United Kingdom. For the stent graft, the rationale is not for the immediate result, but with the use of the stent, you can deal with the elastic recall, but the proliferation is more important. And then some author promote the use of stent graft to deal with the neoantimal hyperplasia. We have 3 locations with a good result with the stent graft. Is the first of these 3 is vein graft outflow. We have 2 randomized trials which highlight the high 6 months permeability for the stent graft rather than the angioplasty alone. And one meta-analysis on 1,000 patients confirm the good result of the stent graft with less loss of patency at 6 months. With this we have enough result to indicate this use in first line treatment. The second location are less documented but existing is the cephalic arch stenotic veins with a greater permeability of the stent graft at 6 months compared to bare metal stent or to balloon alone. And one thing it is interesting is the durability of this result with an easy secondary patency rate. It's not the primary but a secondary patency rate at 1 year. It's quite about 100% for stenosis of the cephalic arch stenosis. So quite good results with stent Covera. The third location for the use of stent graft is the in-stent stenosis in a randomized controlled trial. Folker report the result of the rescue cohort, and they observe a better result with the stent graft versus angioplasty alone in the in-stent restenosis at 6 months. This result is quite bad with less than 20% at 6 months, but we are dealing with restenosis instant, and the stent is implanted for difficult stenosis. One point for the stent graft is the topography of the implantation, and we tried in the two international recommendation, it's mandatory to put the stent graft outside the cannulation zone, but this recent paper shows that they need to put stent graft for rescue situation in 40 patients on 5 years, and they observe a good permeability at 1 year, and there are 2 patients follow up after 2 years, and there are good secondary patency rate with this graft with no stent fracture and no stent infection. This is an off-label use for this stent graft on the cannulation zone, but it shows that it could be possible. The recommendation for the stent graft is relatively clear. You need to avoid the use of bare metal stent in the inflow cannulation zone and cephalic arch. It could be used in central vein stenosis. The self-expanding stent graft could be used in first line to treat graft vein anastomotic with better results than the cutting or high pressure balloon. The stent graft is a little bit superior rather than the balloon for the treatment of in-stent stenosis, but the result is only at 6 months. We have no idea of the longer patency, and the recommendation explains that we have to first consider the consequences of this implantation of the future arteriovenous access, especially if you close collateral or venous inflow. So to conclude, the fistuloplasty, the angioplasty with balloon remains the first line treatment. With high or ultra high pressure balloon, it leads to a 100 technical success. Cutting balloon have not demonstrated superiority on high pressure balloon. The drug eluting balloon have more recently seems to increase the patency at 6 and 12 months without any morbidity, specific morbidity. Stent graft could increase the patency in the cephalic arch, the graft vein stenosis, and in stent stenosis. In all the recommendation highlight the fact that this is a case-based decision according to the access plan. And to finish, I share one table adapted from the paper from Jefferel to adapt the treatment according to the location, inflow segment, cannulation, outflow, cephalic arch, and central vein. For all the location, the angioplasty is the first line treatment. In the cephalic arch, you can associate a stent graft. For the central vein, you can discussing stenting. The bare metal stents are not recommended except for the central veins. Drug coating balloon could be proposed for early recurrences, except in the central vein. There are no evidence for the benefit of this cutting balloon in the central vein. And for the late recurrence, after 6 or 12 months, you can consider the same tools that you have used at the first treatment for the de novo procedure. So I'm sorry not to be able to answer to the question today, but you can send me an email and I respond with great pleasure. Have a good Congress, and I hope that I can see you very quickly. Bye.